adolescents with unilateral hip arthritis, usually secondary to septic arthritis or a slip capital epiphysis. Arthrodesis carries with it, unfortunately, a problem with not only social awkwardness and some problems in terms of personal life, but also has a history of resulting long-term in problems with the opposite hip, the knee on the same side, and of course the lumbar spine. So arthroplasty is increasingly favored as the option for the management of hip arthritis because of the excellent short-term results of joint replacement surgery. Now the problem, of course, with arthroplasty, particularly in young adults, is excessive wear, osteolysis, and eventually catastrophic failure, such as you see here. In order to meet the concerns, alternative bearing surfaces have been introduced and are now widely used in the treatment of hip arthritis, particularly in young adults. They are defined as hard-on-hard, such as metal-metal arthroplasty, which includes resurfacing, ceramic-ceramic, and more recently, ceramic-on-metal. The hard-on-soft alternative bearing surfaces all use cross-linked to polyethylene or vitamin E treated polyethylene. There's a wide variety of these polyethylenes available, and they can be matched to metal, ceramic, or oxinium. Now, all alternatives to traditional total hip replacement have some drawbacks, and the question really is the risk to benefit ratio for patients who will have an alternative bearing surface. It's not working very well. There we are. So what about metal-metal? Well, there's no question that blood ion levels of chromium and cobalt are elevated in all patients that receive metal-metal hip prostheses. There's also a lymphocytic infiltration in a small number of patients referred to as alval, which may result in such phenomena as pseudotumors or significant soft tissue destruction. There is the problem of allergic phenomena to metal, and of course, like all hard bearing surfaces, noise may be a problem. Resurfacing arthroplasty has all the problems of metal-metal, in addition to the potential of femoral neck fracture occurring early after surgery or late, avascularity of the femoral head, and of course diminished revision options should the primary resurfacing fail. Here's an example of a unipolar hip resurfacing, and this is 2 years after the operation. Patient's physically active at work and has a stumble and fall, and you can see that he now has a femoral neck fracture. And at the time of revision, there's a fracture originating at the superior aspect of the femoral head, and you can see that this is a consequence of avascularity of the bone at the junction of the cup. And I anticipate that this will be a more common phenomenon than we anticipate as we watch resurfacing arthroplasties age over time. Now, the ceramic articulation has been in use for approximately 25 years through a variety of iterations, and it has some problems. First of all, there are limited head and liner options. Unlike metal heads and polyethylene liners, you can't have an infinite variety of head depths, nor can you have lipped or augmented liners. Breakage still occurs. It's rare, but it does occur. If the hip does wear, the wear particles are abrasive, which limits your revision options. And when the ceramic components are inserted, there's a potential for the ceramic to damage either the trunnion of the femoral component or the shell. And finally, and perhaps most significantly in North America, is the issue of noise. which is uncommon, but does occur with virtually all of the ceramic hip types. Here's a patient who had a previous femoral neck fracture, went on to a non-union, had a corrective osteotomy to heal the non-union, which did heal, but eventually developed avascular necrosis, and was converted to a ceramic on ceramic total hip replacement because of his relatively young age. And here you see 3 years after that surgery, a fracture of the head, which necessitated revision. So this is a case of mine. I used to say I've never had a head fracture, but I've now had 2 in my practice, so it does happen. Ceramic on metal is the latest ceramic iteration. It's too early to tell yet, but preliminary data suggests that the metal ions in the blood are little improved compared to metal-metal. Now that's just one study from London, Ontario, but it's quite an extensive study, and they have very good data to suggest that metal ions are of similar magnitude, whether or not it's a metal-metal or ceramic-metal articulation. Now the hard-on-soft, they've modified the polyethylene to reduce wear by cross-linking, but again, recent studies have suggested a possibility of increased wear after 5 years. This is work from Sweden, and the question has been raised whether there is in vivo oxidation of these cross-linked polyethylene components, which may occur after a certain length of time in vivo. Now, of course, the advantage of ceramic is its resistance to scratch. Here's the new cobalt chrome head with machine marks. Here's a retrieved cobalt chrome head after about 5 years of implantation. You can see the severe scratching. A new ceramic head, no machining marks, obviously, because this is polished. And here's a retrieved head after 10 years, showing virtually no surface damage. So that's the advantage of ceramic. It's hard, can be polished, and therefore minimizes wear. You have to remember that there's a difference between hardness and toughness. Hardness allows you to increase the polish. We see that in alumina, but we lose some toughness in alumina. Therefore, we see head fractures. Toughness increases fracture resistance, and we see that in zirconia ceramic. Unfortunately, as zirconia ages, it undergoes a monoclinic transformation, which increases surface roughness and leads to increased failure. This is our experience with this. As you can see, 28 patients with 30 total hip replacements with zirconia heads. There's the age breakdown, the diagnosis. Length of follow-up is quite significant. And these were matched to a control group using 28 millimeter cobalt chrome heads. You can see the comparison between the two groups. There's no significant difference in diagnosis, age, body weight, or follow-up. The patients were assessed annually, the WOMAC and the Harris hip score. Here's an example of the problems. You see, patient on the right has a zirconia head, on the left a cobalt chrome head. You can see that this is starting to wear significantly at about 5 years. And here we are a year later, virtually complete wear on the right side. The retrieved specimen, marked polyethylene wear secondary to roughening of the zirconia. And the results show a significant increase in acetabular revision secondary to the zirconia components because of this phase transformation. So we no longer use zirconia, and I don't think zirconia is used as a separate ceramic anywhere in North America. We then undertook a long-term randomized clinical trial comparing ceramic on ceramic with ceramic on standard polyethylene in patients under the age of 60. We started this trial 10 years ago, and you can see that we have 56 hips and 55 patients, all same femoral component, same acetabular component, but randomized by closed envelope to either a ceramic, Morse taper, alumina liner, or polyethylene liner. Investigators and patients were blinded. So we had 26 ceramic on polyethylene and 30 ceramic on ceramic. You can see they were young. We had 2 deaths at 2 and 6 years. These were unrelated to the surgery. 1 failure in each group, 1 revision for dislocation, 1 revision for pain. So we had 54 hips and 53 patients available for follow-up. 4 were lost. You can see that their hip score continued to improve over their follow-up. There was no difference between the scores, and interestingly, no noise in these patients. The wear analysis showed wear in virtually every ceramic on polyethylene, but interestingly, by 9 years, there was also some evidence of wear in 12 of the 23 ceramic on ceramic hips. The annual wear was 5 times higher in the ceramic on polyethylene patients. So our conclusion from this trial was it's a midterm trial at 9 years. There's significantly greater wear with ceramic on standard polyethylene, but perhaps ceramic on cross-linked polyethylene would improve the situation. We also concluded, based on this study, that ceramic on ceramic is a safe and durable bearing surface. It avoids the risk of active metal ions and also avoids the risk of osteolytic debris. Now there's a new ceramic in town. It's a combination of zirconia and alumina in order to get the toughness of zirconia to eliminate fracture and the hardness of alumina to avoid phase transformation of the zirconia with time and improve the durability of the zirconia. There's good lab data for this material, but it's in vivo that counts. And until we have long-term trials of this new zirconia, I'll remain somewhat skeptical of its long-term performance. We need long-term studies to establish the wear patterns in this new material, whether or not there's osteolysis secondary to phase transformation, whether the fracture rate is diminished, the incidence and significance of any adventitious noise with this particular product. Having said that, however, our current practice is to use ceramic in patients under 50 years of age, particularly in female patients with a small acetabulum, and in some male patients who wish to avoid the potential problems of metal on metal. And in my opinion, ceramic continues to have an important role in total hip replacement for the young patient. Thank you very much.